Ladies and gentlemen, start your engines or just the electrical activity on your heart. We are covering EKG interpretation and coronary blood flow. We are going to bring together to you today two topics. Those topics being the heart's electrical activity to produce the EKG and how coronary blood flow supports or fails to support the muscle generating the activity. We're going to be in Guyton Hall today as well as Nagelhout. Remember, Nagelhout is one of the primary sources for your boards. Know it, love it, live it. Also, want to set the expectation. Last week, we talked more about rhythm recognition and some other factors there. This is not rhythm recognition. By the end of the day, you need to look at tracing, know why it looks the way it does, and convert that explanation into an anesthesia decision because that's what boards really wants from you. They're going to have you look at EKG and determine it's a vector question or a supply and demand question. By the time we're done with all the things I'm teaching you in the next couple weeks, you will love some supply and demand. You'll be economic majors. Can't wait for it. Let's begin. Okay, why this matters in nurse anesthesia. The EKG is continuous, not monitor, not a study. Okay. Um, you're going to interpret this in real time under artifact while you're simultaneously managing blood pressure, ventilation, surgical stimulation. The circulator trying to beg you for some kind of start time when you're looking at EKG changes. You got to know it. Three reasons this matter. First, the perioperative tracing changes your plan. Conduction disease, hypertrophy, ischemia, electrolyte effects all alter induction risk. Second, number two, intraoperative ST segments are often the first sign of supply and demand ischemia. Appearing before the blood pressure obviously falls because that's only cycling every 2 to 3 minutes. Third, here we go. Your anesthetized patient can't tell you they're having chest pain. They can't report that angina. You become the surrogate for their symptoms. The second half of today explains the cause behind what the EKG shows. The myocardium already extracts 60 to 70% of the oxygen delivered. So the only meaningful way to increase supply is flow. The left ventricular flow happens during diastole. You've got to remember that. You've got to remember that. So, in thinking like a CRNA, normal sinus rhythm does not guarantee adequate perfusion or oxygen delivery. Electrical abnormality and mechanical or perfusion adequacy are totally different things. Correlate every tracing with blood pressure, end-tidal, SpO2, electrolytes, surgical events before you act, right? If you're looking at something on the EKG that looks odd and looks weird, look down at your pulse ox because that's going to tell you, are those correlating? Are those perfusing beats or are they not? Don't believe the green squiggly lines or whatever color it might be. Look at the whole picture. Make you a better CRNA. All right, learning objectives. You all are doctoral prepared students. I believe that you can read this and understand what we're going to talk about. All right, concept map time. Here we go. From ion channel to anesthetic decision. On this slide, I want you to focus on the chain because it's really the spine of the entire lecture. Okay. Ion currents to current flow to net vector, lead access projection, waveform, and a systematic read. From that systematic read, we branch into four interpretation domains: rhythm and blocks, ischemia, electrolyte and drug effects, and chamber size. And every one of those is an anesthetic implication. I thought this board pearl was very helpful. Every EKG finding traces back to one of the three things: a change in ion currents, a change in vector, direction, magnitude, or timing, and a change in what surrounds the heart. Ask which one before you memorize a pattern. All right, family trip, trying to get the roadmap out. What should you be able to do? This slide is purely as a study aid, okay? So use that effectively. It maps the highest yield content areas to the slide where each is taught. Notice the middle column is written as verbs, things you must be able to do. There's no excuse for not knowing these things. The numeric effects are the cheapest points available: paper speed, box value, interval ranges, resting membrane potential, lead axes, roughly about 0.06 second conduction from the time of the AV bundle to the last ventricular fiber. Learn those cold and hard. All right. Then spend the remaining study time on the actual relationships between these. All right. Alert, alert, alert. Look at the screen. Ventricular action potential. Know this slide or you won't pass boards. Guaranteed. This is what I want you to know. I want you to focus on matching each phrase to its ion current and then to the EKG correlate. Because that mapping is directly tested, no questions asked. Phase zero is a rapid depolarization from fast sodium channels opening, and it corresponds to the QRS. Phase one is an early repolarization, just very briefly. Phase two is a plateau as calcium influx balanced against potassium outflux. Now, notice in phase two, the L type of influx, and that's the L type channel. Okay, this channel is L type, meaning long. It gives a stronger contraction during this time. So, coming off coronary artery bypass, or if you need a potent vasoconstrictor, or you need your blood pressure up, you got a little calcium chloride, and you got a solid line, meaning 20 that you can power flush with a 10 cc, or a solid 18 that you trust. Give us some calcium chloride, and you'll see a pretty good effect on the blood pressure because you're influencing that type L calcium channel. So this area also corresponds to the ST segment and is the also phase supplying calcium for contraction. Phase three, this is the potassium efflux and produces the T wave. Phase four is a resting potential maintained by the sodium potassium ATP ACE pumps. In the ventricular muscle, it sits at about negative 85, negative 95 millivolts. All right, a little pearl for boards here. Phase zero, fast sodium influx equals QRS. ST segment equals phase two. T wave equals phase three. And the ventricular resting membrane potential is negative 85 to negative 95. These are correlations for the highest yield facts in the entire cellular section here. All right, another anesthesia pearl here. Anesthesia altering these currents alters the tracing. Hyperkalemia raises the resting potential, and slows phase zero, widening the QRS. Local anesthetics and other sodium channel blockers depress phase zero, and hypokalemia may, in many drugs, prolong phase three repolarization, producing a long QT and a torsades risk. What's one of our what are most primary drugs affecting that? Zofran, fentanyl, sevoflurane. A lot of drugs that we're giving prolong that QT. You got to know what you're doing with those. Right. Myocyte versus pacemaker action potential. On this slide, I want you to focus between the fast response and the slow response tissues, okay? Because it explains really all of our rate controlling pharmacology between fast response and slow response tissues. Ventricular muscle sits about what? I told you this last slide, negative 85 to negative 95 with a flat phase four. So it's got to be stimulated, it's got to be hit. Okay. Nodal tissue, however, sits at negative 55 to negative 60 with a spontaneously, you see that here the flare in my voice, spontaneously drifting phase four. That is four is a automaticity, right? It's drifting. It's ready to be fired off. It's automaticity. Great little word I made up there. Critically, nodal phase zero uses slow calcium channels, not fast sodium channels. So here for boards. The single fact explains why calcium channel blockers and beta blockers work on a rate and AV node conduction, while sodium channel blockers work mainly on the ventricle. VTAG, VFib, get a little sodium, get a little lidocaine, boom. Usually fixes that, especially coming off bypass. The anesthesia implication here, okay, so you give norepi, what's it going to affect? It's going to steepen phase four to increase rate, increase contractility with that nodal response, whereas acetylcholine is going to hyperpolarize the node and slow it down. And that's what you're seeing during a vagal response with laryngoscopy, peritoneal extraction, the celiac response, or neostigmine. All right, refractory periods and why cardiac muscle cannot tetanize. Fascinating word. Love it. All right, skeletal muscle can be stimulated repeatedly uh, to produce summation and tetany. If the heart did that, it would never relax to refill, and the cardiac output would stop. So thank goodness those are two different types of muscles. Because the ventricular refractory period lasts about a quarter to a third of a second, as long as the contraction itself, cardiac muscle cannot summate. For boards, the phrasing is direct. Cardiac muscle does not exhibit wave summation because of its long refractory period. The clinical dangerous part of this is the relative refractory period, right? The vulnerable window between the peak of the downslope of the T wave, when you see the PVC fall in that T wave, you ask yourself whether the QT is long and whether potassium or magnesium is low, because bow chicka bow, you're about to have some good times with RNT degenerating into polymorphic ventricular tachycardia. You're going to give some of that lidocaine, that's sodium channel blocker. You're going to shock them. You're going to give some amiodarone. You're going to have all kinds of fun. So careful with the old RNT phenomenon. Bites you every time. Right, autonomic modulation and rate conduction. Exam exams test the mechanism rather than direction. So let's learn the mechanism words. Sympathetic stimulation through norepiaxon beta 1 receptors steepens the phase 4 slope of the nodal cells, raises the rate, increases the contractility. So the correct board answer here is that norepi increases both heart rate and contractility. Parasympathetic stimulation through acetylcholine acts on the M2 receptor, right? The M2 receptor is right there at the heart. It hyperpolarizes it, and the nodal cell, taking it from a further from the threshold and slowing the rate. That specific word hyperpolarization is what you're going to be tested on. The operating room, you're going to see this generate swings constantly by incisional and by incision, a light anesthesia, and produces a sympathetic surge that drives demand ischemia. Again, peritoneal traction, or the old 5 and dime reflex, cranial nerve 5, cranial nerve 10, 5 and dime reflex, also known as the oculocardiac reflex. And neostigmine produce the vagal response that drops your heart rate. That's when we often pair it with what? Glycopyrrolate. Boy, oh boy, anatomy and physiology. All right, cardiac conduction system. Focus on the hierarchy and the timing here. SA node normally fires to 60 to 100 beats because it's fast intrinsic pacemaker. The AV node backs it up at 40 to 60. The Purkinje tissue is about 20 to 40, and that hierarchy is what you're seeing whenever you see escape rhythm beats. Slower and wider the escape, the further down the system the failure has occurred. The avial node delay is functional, not a defect. It lets the atrial contract first before the ventricle contracts, which matters enormously in a stiff, hypertrophied ventricle where the atrial kick may supply 20 to 30% of filling. Knowing that transmission from the AV bundle to the last of the ventricle fibers takes about 0.06 seconds or second, and because the RCA supplies what? The AV node, the SA node, particularly the AV node, about 85 to 85 to 90% of the people, inferior ischemia predictably produces bradycardia and AV block. Conduction, velocity, and timing. Focus on the two extremes here. The AV node is the slowest conducting tissue in the heart, and the Purkinje system is the fastest, right? It's not the rate, it's the velocity through those areas. Okay. The AV node slowness creates the PR segment. The Purkinje systems speed up, keeping the QRS narrow by delivering the impulse to the entire ventricle almost simultaneously. Boom, all the way through from the AV to the Purkinje system. Connect this directly to a bundle branch block where the Purkinje conduction is lost on one side or the other. The impulse must travel muscle to muscle through roughly 1/3 of the normal velocity. So the QRS widens past what's the typical duration? 0.12 second. The anesthesia implications is additive risk, hyperkalemia, sodium channel blockers, ischemia, hypothermia, vagal tone, increased vagal tone, all slow conduction in a patient who already has conduction disease. Those effects just stack on top of each other, not where you want to be. One of the most commonly misunderstood points in EKG teaching is that the EKG records potential differences voltage between electrodes. It does not record contraction. At any instance, the depolarized region is electronegative, and the still polarized region is positive. Currents flow between those two, and the summed potential is what each lead projects. When the ventricle is entirely depolarized, no current flows, and we return to baseline. That's why the QRS starts and ends at an isoelectric line. The exploring electrode rule is one that you will use constantly. Currently moving toward the positive electrode describes an upright deflection. Okay, electricity moving towards an electrode is a upright deflection. Moving away from an electrode is a negative deflection, and current perpendicular to the lead gives an isoelectric or biphasic complex. All right, little pearl here. Electrical activity is not perfusion. PEA, pulseless electrical activity, is the proof. A textbook complex can exist with zero cardiac output. Always confirm a pulse on or an arterial waveform, or just look at your pulse ox. You're gonna know. Also in title, throw that in there as well. All right, boy, oh boy. Hope you got lots of caffeine. This one's gonna be rough. EKG paper calibration and rate calculation. Get hyped. Turn time into boxes and every interval's question becomes trivial. Standard paper speed is 25 millimeters per second, which makes each small box 0.04 second and each large box 0.2 second. So 5 large boxes equals 1 second. Vertically, standard calibration is about 10 millimeters per millivolt. For rate, use the 300 rule for regular rhythms. 300 divided by the number of large boxes, or 1500 rule with the small boxes when you need precision. And the 6-second rule times 10 for irregular rhythms like atrial fibrillation. All right, verify calibration before you trust the amplitude. At half standard, true left ventricular hypertrophy voltage can look normal and switch from monitor to diagnostic filter mode just before judging ST segments, because monitor mode deliberately filters low frequencies and distorts the ST. Something interesting to know there. Focus on the difference between a segment and an interval. Between a segment and an interval. Pretty important. The exam exploits that distinction, okay? A segment is the flat line between waves. Segment is a flat line between waves. The interval includes a wave plus a segment. Segment is flat line between waves, and interval includes the wave plus the segment. The PR segment is a flat portion representing the AV node delay, where the PR interval runs from the beginning of the P wave to the beginning of the QRS, and therefore includes both the atrial depolarization and the AV delay. Similarly, the ST segment is the plateau where the ventricle is fully depolarized, corresponding to phase 2, right? Those long type calcium channels in phase 2, while the QR interval spans both ventricular depolarization and repolarization. The common mistake is to call the PR interval the AV delay. The delay is specifically the PR segment, not the interval. Now, oftentimes we do talk about PRI and PR intervals and how we measure those. Normal intervals and their abnormalities. 4 numbers and what is abnormally, what each abnormality implies. The PR interval of 0.12 to 0.2 second is normal. That's completely normal. Longer means the first degree AV block or slowed AV conduction, while shorter suggests some pre-excitation such as Wolff-Parkinson-White, also known as WPW, or a junctional rhythm, where the P wave is not found as quickly or is faster onset. QRS is 0.08 to 0.12 second. Wider means bundle branch block of ventricular rhythm, hyperkalemia, sodium channel blockade. And the corrected QT, the QTC, should be under about 0.44 seconds in men and 0.46 seconds in women. A lot of times you're going to see QTCs look at 440 or 440 versus 460. Many a time, clinical relevance happens at a QTC of 500 or greater, or zero point 0.5 or greater in the way that this is measured. So really important there. Prolonged QT plus low potassium or magnesium plus QT prolonging drug is a Torsades recipe. And we give many QT prolongations routinely, including ondansetron, the old droperidol, black box warning, because people will make some good money, haloperidol, amiodarone, methadone, and sevoflurane. Methadone is an interesting drug, by the way. It's one of the few narcotics we give that also has a noted QT prolongation. Now fentanyl does too. It's just not as much as methadone. Methadone also has NMDA properties as well as mu receptor properties. It's a really good drug as long as you don't have QT prolongation. So how are you going to treat that? A little IV mag, 2 grams bolus, and we're going to defibrillate these patients if pulseless at 200 joules. Back to the old concept map. Action potential to EKG waveform. Let's use this map in both directions. So read left to right and explain the waveform's genesis. And then now read in reverse, which is how you will use it clinically. Okay. When you see a widening QRS, you have a phase 0 problem. Think hyperkalemia, sodium channel blockade from a local anesthetic toxicity. When you see long QT, you have a phase 3 problem. Think potassium, magnesium, other drugs that we just talked about giving. When you see ST changes, though, you have a plateau phase energy problem. Think ischemia. That reverse reading turns a memorized map into a differential diagnosis. All right, get hyped. J point is the J money. You got to know this. We cannot simply trust the baseline of the machine prints that we have because stray currents from the skin potentials and differences in ionic concentrations make true zero unpredictable. However, one specific instant, the J point where the QRS ends and the ST begins. I'm going to say that again. J point is at where the QR ends and the ST begins. The entire ventricle is depolarized, no current is flowing forward, and the potential is genuinely zero. We draw a horizontal line to the J point and measure any injury potential from that line. The heavily tested consequence that can injure current displaces the TP segment, meaning what looks like ST elevation may in fact be relative TP depression. Clinically, we measure ST deviation about 60 to 80 milliseconds after the J point, and if your monitor's measure point is set wrong, then your ST trend could be wrong. Biggest thing here is look for isoelectric at the J point, and if you're not isoelectric there, depression or elevation, you probably have some degree of ST abnormalities that you need to be further investigating, even though that ST measure is a little bit past the initial J point. But J point is something people don't teach enough, and I think it's very clinically relevant. All right, vector basics. I'm not going to lie, vector is important to a certain point. However, you're not going to get tested a lot on just pure vector. There's going to be some other things we talk about in this lecture that are more important than vector, but something you should be aware of. There's 3 properties: direction, magnitude, and polarity. Guyton defined vector as a arrow pointing in the direction of the electrical potential generated by current flow. Arrowhead in the positive direction with a length drawn proportionally to voltage. Consider moving considerably more current flows downward from the base towards the apex than upward, which is why the summated instantaneous vector points base to apex, keeping the apex positive with respect to the base through most of depolarization. Okay, vector magnitude is a rough readout of muscle mass and its surroundings. Hypertrophy lengthens the vector, loss of muscle from an old infarction, or insulation from effusion or emphysema shortens it. Okay, that's really what I want you to know right there. This anesthesia pearl when it comes to vector. That's going to help us when we come to axis. But before we get to the beautiful world of axis, we're going to be in vector direction expressed in degrees. Every axis depends on this convention. When a vector is exactly horizontal and directed toward the patient's left, it extends in the direction of 0 degrees. Towards the patient's left armpit, 0 degrees. From that reference, the scale rotates clockwise. Okay, so straight down is 90, all right, down towards the old genitalia or your feet, probably better worded, is 90. Towards the patient's right, okay, right armpit's 180. And straight up is negative 90, same as plus 270. The normal mean QRS vector sits at about 59 degrees. And you can see on this slide where that kind of moves down from the SA node, AV node, Purkinje fibers. You can see that vector of movement there. Um, don't call Do not overcall axis deviation. Deep expiration, supine position, obesity, push the diaphragm up, shifting the axis leftward. A deep inspiration, standing in tall, lanky, habitus people, shift it rightward, and those are normal variants. All right, Einthoven's triangle and the hexaxial reference system, two testable items. First, Einthoven's law. Lead 1 plus lead 3 equals lead 2. That's not a memory trick. It follows a geometric or the geometry of the triangle. Okay. And it's a quick sanity check for lead placement. Second, the lead axes. 1 equals 0, 2 equals plus 60, 3 equals plus 120, AVR equals 210, AVF equals 90, and AVL equals negative 30. Those 6 numbers should be automatic. Yeah, that's a fun one to learn. Notice the normal mean vector is about plus 59 degrees, like we talked about earlier, sits right between lead 2 and AVF, which is exactly why both are strongly positive in normal heart. So 2 and AVF, 2, 3 and AVF all like come at you, right? And why AVR is pointing the opposite way, because it's up there. AVR is what, plus 90? No, excuse me, I apologize. Plus 210 up there next to that 270 that we talked about it directly north. An upright complex in AVR should make you really suspect some reversal of limb leads or dextrocardia before you diagnose pathology. The hexaxial reference system. Each lead is a pair of electrodes, and the direction from the negative to the positive electrode is that lead's axis. Guyton explicitly tells students they must learn these axes and polarities to understand the rest of the chapter, and it's important that you know this stuff. The clinical layer, which wall each lead views, and in the operating room, that mapping is what lets you choose which monitor lead intelligently, rather instead of watching whatever monitor the machine chooses to give to you. All right, vector direction determines the deflection. A lead records the projection of the heart vector onto its own axis. When the vector is parallel to the lead axis and pointing in the same way, essentially the entire voltage is recording. So the board answer is that the alignment produces maximal voltage. Pointing the opposite way gives a deep negative deflection. When the vector is nearly perpendicular, recorded voltage is very low, isoelectric, or biphasic, like we've said before. The exam favorite technique that falls out of this is find the isoelectric limb lead, and that means axis is roughly perpendicular to it. The anesthesia implication is that no single lead sees everything, which is precisely why we choose to monitor leads deliberately. And do you know what those leads are? Those leads are 2 and V5. So we're seeing the inferior side of the heart, and we're also seeing a lateral, maybe getting a glimpse around to the anterior portion of the heart. But those are the ones we choose to monitor. All right, take the instantaneous vector A. From the center of the reference system, for each lead, drop that perpendicular from the tip of A onto the lead axis. Okay? The piece of the axis from the origin to where that perpendicular lands is the projected vector. Its direction tells you polarity, its length tells you amplitude, and Guyton Hall explained all three projections point positive, and lead 2 records the largest because the vector A is most nearly parallels the lead 2 axis. Okay, so if you see that, you look at vector A, the red line, the red arrow pointing towards lead 2. That's why lead 2 is so positive. Okay, so once students can do this, running it backward and find the mean axis becomes intuitive. Again, some of this is ivory tower knowledge. Some of it's not. All right, normal ventricular depolarization and QRS genesis. Please don't get too excited about this slide. All right, focus on QRS as a moving vector rather than 3 separate letters. At 0.01 second, the impulse has depolarized only the left side of the septum, producing a brief left to right, vector, left to right vector. The small septal Q with low voltage and lead 2 is the largest. By 0.02 seconds, so one more 0.1 second, much of the ventricular mass is depolarizing, so it's a very small amount of time. The vector is longest, the voltage peaks, the R wave, all right, so QRS, a lot of voltage going on that R wave. By 0.035 second, the outside of the apex has become electronegative and neutralizes positivity on other epicardial surfaces. So the vector shortens and shifts leftward. At 0.05 seconds, the vector points toward the base of the left ventricle, making leads 2 and 3 negative, while lead 1 stays positive, the S wave. And by 0.0 second, everything is depolarized and all returns to 0. So here's the board pearl. The small septal Q wave is normal and lateral leads. A pathologic Q wave is greater than 0.04 seconds wide or deeper than 25% of the R waves, signifies prior infarction with loss of muscle mass. Boom. That's what you want to know. I don't care if you know the rest of all this stuff. Pathological Q wave is greater than 0.04 seconds wide, and really what you're going to see is it's deeper than 25% of the R wave and signifies prior infarction. You see that, you need to know an ejection fraction on that patient because they could have significant cardiac disease that you're unaware of. All right, repolarization and the T wave, a generally counterintuitive fact that examiners love. Repolarization is electrically the opposite of depolarization. Go figure. So you would predict an inverted T wave, but the T wave is upright in the same direction as the QRS. Good question. The reason is the septum and the endocardial areas depolarize first, and but they do not repolarize first. So septum and endocardial depolarize, but they don't repolarize first. The epicardial surface, especially near the apex, repolarizes the endocardium repolarizes first and the endocardium repolarizes last. Because the outer apical surfaces repolarize before the inner surfaces, the positive end of the repolarization vector again points towards the apex. All right. So it's based on the inside versus the outside repolarization. And because the outside repolarizes first, you're going to give a positive T wave. Okay. The mechanism and the clinical link: high blood pressure inside the left ventricle during contraction greatly reduces coronary blood flow to the endocardium. We know this, and you'll see this in week 10, I think, which slows repolarization there. That is the same anatomy that makes the subendocardium the first layer to become ischemic. Connect this slide to everything we say later about supply and demand. The endocardium is the first layer to become ischemic. Preach it, know it, love it. Right, atrial depolarization, the P wave, and the hidden atrial T wave. An elegant contrast. In ventricles, the endocardium repolarizes last. We just talked about that, keeping the T upright, the T wave upright. In the atria, the opposite happens because the atria have no Purkinje system. The conduction is slow, so the musculature around the sinus node depolarizes long before the distal atria. Okay, long before that distal atria, the sinus node depolarizes. And that same sinus nodal region repolarizes first. That makes the atrial repolarization vector point backward relative to the P wave. So it's inverse of the P wave. So the atrial T wave is normally negative. It occurs about 0.15 seconds after the P wave, and it places it inside the QRS. So it's almost always obscure. You're not going to see that because it's hidden inside the QRS. Vector cardiogram. Here we go. The QRS is one continuously moving vector, not a set of discrete events. Between heartbeats, the muscle is polarized and the vector tip rests at zero. Okay. As the septum depolarizes, the tip leaves zero and more muscle depolarizes and the vector grows and swings. As depolarization completes, it shrinks back to zero. Guyton Hall made the important point here that vector is greatest when about half the heart is polarized and half is depolarized. Maximal opposition means maximal signal. The clinical payoff here: anything desynchronizing that wavefront smears the loop. That's why a bundle branch block, pacing, hyperkalemia, and ischemia all widen and distort the complex. That's pretty helpful. Why it looks weird when those things are happening. Right, determining the mean electrical axis. I'm all about some axis. All right. Um, Focus on the logic rather than drafting here. Focus on mostly the logic of this. First, find the net potential in leads 1 and 3. If any part of the recording is negative, subtract that from the positive portion, then plot the net potential along its lead axis with the base at the intersection. Drop a perpendicular from the tip of each. Where those perpendiculars cross is the apex of the mean QRS vector. The intersection of the lead axes is its negative end. The direction of that vector is mean electrical axis, about 59 degrees, normally, with a normal range of between -30 to +90 because of anatomic variation in the Purkinje distribution. Hope you're loving your life right now. All right, for realsies, this is something I've talked to you about before. This stuff matters clinically. Okay, bedside access quadrant method. A method you can do in 5 seconds. Look at lead 1 and lead AVF. What was that again? Lead 1 and lead AVF. Where is that going to be on the 12 lead EKG that you're looking at? Lead 1 is going to be in the top left corner. You're going to go over one column. You're going to go all the way down to the bottom because you're going to have 2, 3, and AVF right there. Second column, very bottom, 1 and AVF. That's where you're looking at, okay? Both positive is normal. So both positive deflecting is normal. Lead 1 positive with AVF negative suggests left axis deviation. Okay, confirm with lead 2 because if lead 2 is negative, the axis is beyond 30 degrees. Lead 1 negative with AVF positive is right axis deviation. Okay, Lead 1 looking down is negative. AVF looking up is positive. Right axis deviation, right together, left apart. So left apart would look like this. Lead 1 is a positive upward deflection. AVF is a negative downward deflection. They are left apart and then right together versus your axis. Okay, why is that important? What does that mean? Notice this: left axis deviation, left ventricular hypertrophy, hypertension, aortic stenosis. Lights are going off in your brain right now. Whoa, okay, check this out. What's going on? Do I have left axis deviation where one is up, AVF is down, left bundle branch block, left anterior fascicular block, inferior MI, WPW, okay, right sided, right ventricular hypertrophy, pulmonary hypertension, PE, COPD, cor pulmonale, right bundle branch block, lateral MI, left posterior fascicular hemiblock. Right. If you got extreme access, you're in a ventricular rhythm, maybe VTAC, and possibly even just really, really bad hyperkalemia. But knowing those access in this scenario, it just is such an easy, low-hanging clinical fruit, high yield opportunity to impact patient care. So please take the time to know this. All right, why the axis shifts? Two mechanisms here. Uh, two different findings. Okay, it's basically hypertrophy. Hall or Guyton and Hall give two reasons why axis points toward hypertrophied ventricle. There is more muscle generating greater potential on that side, and depolarization wave takes more time to travel through the thickened wall, so the normal ventricle finishes first and becomes electronegative, while the hypertrophied side remains strongly positive. So with the bundle branch block, the logic is different. Normally, two ventricles depolarize almost simultaneously and their potentials largely cancel. But when one bundle is blocked, a normal ventricle depolarizes 2 or 3 times faster, becoming electrical negative, and the strong vector points towards the late depolarizing blocked ventricle. QR restoration is the discriminator. Hypertrophy deviates the axis with near normal or slightly prolonged QRS. Bundle branch block deviates it with a QRS clearly beyond the 0.12 seconds. This single sentence answers a large family of exam questions. All right. What do you have? Why is you have this bundle branch block? Why do you have this widened QRS? Because you have a hypertrophied ventricle or you have some kind of bundle branch block. All right, left ventricular hypertrophy. Let's convert that EKG finding into my anesthetic plan. The EKG shows increased voltage, left axis deviation, a mildly prolonged QRS. Remember, left axis, left apart. Lead 1 is up, lead AVF is down, and there's strain changes. This is defined as a high voltage EKG and summed QRS greater than 4 millivolts across 3 standard leads. But clinically important content is the physiology. Concentric, thick, muscular hypertrophy, concentric, produces a thick, stiff, small cavity ventricle with diastolic dysfunction. It's thick, it can't fill, has diastolic dysfunction that depends on both preload and atrial kick. So LVH in the setting of AFib, not a good combination. The dangerous physiology is the demand to supply squeeze. High wall tension, tachycardia, raise oxygen demand while thickened wall, and any fall in diastolic pressure limits subendocardial supply. Coronary perfusion pressure equals diastolic blood pressure minus your EDP, your end diastolic pressure of your left ventricle. So defending diastolic pressure is defending the myocardium. So read a high voltage QRS on the pre-op EKG as an instruction. This ventricle punishes hypotension and tachycardia. Plan for a smooth induction, phenylephrine drawn up to keep that diastolic blood pressure high, and point your monitor lead at the lateral or anterior wall. So you want to look at V1 through V4, or you want to look at V5 when you have left ventricular hypertrophy. Right ventricular hypertrophy and RV strain. Right ventricular behaves very different from the left. I think we kind of know this. Right axis deviation and a tall R wave in V1 point towards pulmonary hypertension or chronic lung disease. A thin-walled RV was built for low-resistance circuits, not meant to do the lion's share of the work like the left ventricle. It tolerates acute increases in afterload extremely poorly. It dilates, then it fails on you. Not a good scenario to be in. Two physiologic facts drive management. First, the normal RV is perfused through the cardiac cycle rather than mainly during diastole. So systemic hypotension directly threatens pressure-loaded right ventricle. Second, a dilating RV pushes the septum leftward and impairs LV filling through ventricular interdependence. Management reduces to one idea: don't raise the pulmonary vascular resistance, and do defend the systemic pressures. Right, get the pressure down a little bit. Don't let them get hypotensive or hypoxia and hypercarbic. Clinical red flag. Hypoxia plus hypercarbia plus rising airway pressures produces a new right axis deviation or RV strain, signals RV failure. It's a vicious cycle. A lower aortic pressure starves the RV, which fails further oxygenate, ventilate, and perfuse. Epi is your friend in right ventricular failure. I want to say that one more time. Epi is your friend in right ventricular failure. All right, QRS voltage, high and low, high, low, and electrical alterans. Sounds wonderful. Voltage reports two different things: how much muscle is there, and what sits between that muscle and your electrodes. High voltage usually means increased muscle mass. Low voltage splits between two mechanisms examiners like to contrast. Conductive fluid from pericardial pleural effusions short circuits the potential so less current reaches the surface. And then air, as an emphysema, does the opposite. It insulates and prevents spread of the voltage across the surface. Loss of muscle from old infarctions or amyloid infiltration also lowers voltage. And Guyton notes that this combination typically also produces a long QRS. Electrical alterans is most commonly seen with a pericardial infusion. The heart is literally swinging in fluid, changing its vector orientation beat to beat. So you're going to see your R waves alternate kind of up and down, almost in like a organized sinus rhythm, torsades type fashion, without being in torsades, without having a wide complex. All right, QRS duration and its meaning. The physiological anchor that makes every number make sense. The QRS lasts exactly as long as part of the ventricle is depolarized while part is still polarized. Therefore, anything that slows or desynchronizes conduction widens that QRS. Hypertrophy and dilation prolong it modestly by lengthening the path when the Purkinje system is blocked. Conduction falls to roughly one-third of the velocity, and that complex widens to 0.14 seconds or more. So the normal QRS duration is to be memorized at 0.08 to 0.12 seconds. A little pearl for you: QRS widening in front of you is an emergency vital sign, not as a good scenario. The two fastest or reversible causes in the OR, um, uh, you have hyperkalemia. You want to give calcium first. And then you also could have a local anesthetic systemic toxicity, a last event. You need to do lipid emulsions in that scenario. Treat empirically. Don't wait for the lab. All right. Treat what you see. It's not going to kill somebody to give a little bit of calcium. It's not going to kill them to give a lipid emulsion, but it will kill them if you don't treat it. All right, two hallmarks of morphologies and two anesthesia consequences. Bundle branch block comparisons. The right bundle branch block, the right ventricle depolarizes late, giving that RSR or RSR prime pattern, also known as rabbit ears, in V1 and V2. A wide S wave in 1 and V6, and a rightward access shift. So right together. Remember, lead 1 would be looking down, lead AVF would be looking up. Right together. In left bundle branch, the left depolarizes late, giving a broad notched R wave in the lateral leads and abolishing the normal septal Q. Both widen the QRS to at least 0.12 seconds, probably more. Clinically, they are not equivalent. Right bundle branch is common, present in roughly 1% of hospitalized adults, and frequently there's not a whole lot to do about it. Left bundle branch block, though, indicates real structural heart disease from hypertension, coronary artery disease, aortic valvular disease like aortic regurgitation, where that is getting very, very large, or cardiomyopathy. So you suddenly have a new left bundle branch block in the OR, especially during hypertensive or tachycardic episodes. That may signal ischemic changes, and it masks ischemia because ST changes are happening, but you can't see it because of that left bundle branch block is obliterating. Where would you look for that ST change? At the J point. And your anesthesia pearl for this pre-existing left bundle branch blocks, pulmonary artery catheters risk complete heart block. So you have a left-sided block, you're putting the pulmonary artery catheter down the SVC into the right atrium, into the right ventricle, stimulates the right ventricle. Right ventricle gets really unhappy. As you're pushing back up, all of a sudden, boom, you're in a complete heart block. Happens in rough 2 to 5% of scenarios. Have pacing capabilities available. Hopefully, if you're floating a swan, either you have a pacing swan or you got some pads on this patient, especially in the setting of left bundle branch block. I saw that just the other day. It's not a fun time. All right, not going to get too crazy about this. Branch block vector analysis. I think you can read the slide. I don't believe we're going to test anything on this, but you can look at the slide, look at the differentiations. A lot of what's said here has been said before. Right, fascicular blocks, also known as hemiblocks in combined disease. Left bundle divides into the anterior and posterior fascicles. The anterior fascicle is thin and singly supplied, so the left anterior fascicular block is the most common hemiblock. It produces left axis deviation with a QRS that is normal or minimally prolonged. And that near normal width is what distinguishes it from a complete left bundle branch block. The posterior fascicle is larger and it has dual blood supply from the LAD and the posterior descending artery. So the left posterior fascicular block is uncommon and implies extensive disease. So you have the LAD feeding that from the front and the PDA feeding that off the RCA from the back on that posterior versus just a single supply on the anterior fascicle. The concern is cumulative. Bifascicular block produces first degree AV block, plus a first degree AV block signals widespread conduction disease, and alternating bundle branch block is a strong pacing indication. Routine prophylactic pacing is not required for stable chronic bifascicular blocks, but have external pads available and chronotropic drugs available. What's a chronotropic drug in this scenario? Dobutamine, dopamine. If you say dopamine, I'm going to think less of you. Epi is where you want to go. Remember that hyperkalemia, vagal tone, beta blockade, calcium channel blockade, hypothermia, and ischemia all slow conduction additively. All right, AV blocks. One distinction between the benign block from a dangerous one. When the PR interval does, what the PR interval does before the dropped beat. In Mobitz 1 Winky block, the PR lengthens progressively until a QRS is dropped, and the block is at the AV node, often vagal or drug related, usually benign. All right, longer drop. Now you have a Winky block. That's what we all heard. If you haven't, you heard it now. Mobitz 2, the PR stays constant. Remember that. That is so key between the second degree type 2 versus a third degree. the PR interval stays constant but simply drops beats, and that block is infranodal, usually in the Purkinje system, and is unstable and prone to progressing to complete heart block. So you got a longer drop. Not as important. You have a consistent PR that drops beats. You better think twice about taking that patient to the OR, or you may put some pads on that patient. Third degree heart block shows complete AV dissociation where the P wave and the QRSs are not even matching up in any way. The management is heavily tested. Okay. Atropine works at the AV node, so it helps with winky block and may be useless or even counterproductive in infra or underneath AV node block, infranodal block. Those patients often need pacing. Stokes-Adams syncope is the classic presentation when the escape pacemaker is too slow to take over the AV block. All right, in a Mobitz 2, clinical red flag. Mobitz 2 a third degree block and infranodal and unstable. Atropine works on the AV node like we talked about. Make it paradoxically works. Go to pacing. Use epi. Man, I guess you can use dopamine if you want to be back in the 1990s. But that's what you need to get with. Get the heart rate up any way you can. All right, so here we are. We have some AV block rhythm strips. You have a first degree AV node block. You have a second degree Mobitz type 1 AV block. Notice that the PRs are progressively longer and they're dropping in QRS. And then you have a second degree AV node type 2, Mobitz type 2 block. Notice that your PR intervals are exactly the same in this one. Okay, this one is a little more dangerous to take to the OR. And then you have a third degree block. Hopefully, you're going to cath lab to get a pacemaker. But you know that you have complete AV and or atrial and QRS or atrial ventricular dysynchrony. Determining the differences between sinus arrest versus sinus pauses. Okay, so in sinus arrest, the rhythm resumes, the RR intervals do not match up. So that's pretty important. Okay, sinus tachycardia really deserves your respect because it's a symptom, not a disease. So if you're treating it, just treating a number, you're not really treating the cause. You have to treat the cause of hypovolemia, light anesthesia, pain, sepsis, you know, shock, whatever it might be. You've got to treat the cause. Problem with tachycardia, though, is that it is one of the single most damaging events for an ischemic heart, so you have to be careful with it. All right, so atrial rhythms. Atrial flutter is a sawtooth pattern. Atrial rate's about 250 to 300, usually 2 to 1 conduction, maybe 3 1 conduction. So a lot of times your ventricles are going to be around 150. Atrial fibrillation is irregular. That's really important. That's the way they say it. Irregular, with no discrete P waves. AV NRT is a regular narrow complex tachycardia about 140 to 220 with P waves buried in or right before or immediately after the QRS. So it's kind of like an SVT is kind of another way to say that. So think like a CRNA here. What hurts your patient in new atrial fibrillation is not the electrical abnormality, but the loss of the atrial contribution to filling, which is 20 to 30% of your cardiac output, that atrial kick you lose. So in a hypertrophied or stenotic ventricle, this can be catastrophic. You can lose whatever it was that you had because that volume chamber in the hypertrophied or stenotic ventricle is limited, and whatever was going to make it in there because you've lost that kick now makes that patient unstable. You may have to do a synchronized cardioversion and add in some pharmacology, whatever that might be. Wolf Parkinson White and pre-excitation, an arrhythmia that breaks the unusual rules. WPW, Wolf Parkinson White, is an accessory pathway through the bundle of Kent. Connects the atrium directly to the ventricle, bypassing the AV node. Because it bypasses the AV node, AV node delay, the PR is short, usually under 0.12 second. And because it pre-excites the ventricular muscle outside of the Purkinje system, the QRS upstroke is slurred, and this is where you get that delta wave. The danger is the atrial fibrillation in this setting. The AV node normally protects the ventricle from conducting um, high atrial rates, or and excuse me, an accessory pathway has really no other protection. So the atrial rates of 400 to 600 can conduct nearly 1 to 1 and degenerate into VFib. So this clinical uh, flag here. In atrial fibrillation with WPW, never give AV node blocking drugs like adenosine, beta blockers, calcium channel blockers, or digoxin. Blocking the AV node forces more conduction down the accessory pathway and precipitates VFib. Not where you want to go. The drug of choice is procainamide, which slows the conduction in the accessory pathway itself. If the patient is unstable, perform a synchronized cardioversion. So procainamide is a sodium channel blocker, affects the ventricles in a very, very strong way. So if you have somebody with WPW, avoid sympathetic surgeons. Make sure they're not light under anesthesia. Make sure they not using ketamine that could increase your heart rate. Inadequate analgesia can all pre-trigger excited tachyarrhythmias. Have a defibrillator ready, procainamide accessible, ensure adequate depth before you put a tube in this patient. Ventricular arrhythmias and RNT. RNT causes when a premature ventricular beat lands during the relative refractory period, roughly the peak and the downslope of the T wave. Okay, when the myocardium is electrically heterogeneous and vulnerable, that is the setup for polymorphic VTAC or VFib, and the risk climbs with a prolonged QT, hypokalemia, hypomagnesemia, and ischemia. The decision rule is equally important. A wide complex tachycardia in an unstable patient should be treated as ventricular tachycardia. Do not spend time distinguishing between VTAC or SVT with aberrancies while the patient deteriorates. Synchronize cardiovert if there's a pulse, defibrillate if there's not. Always scan for reversible causes because we generate a lot of these ourselves with hypercarbia or other acidotic mechanisms. All right, little decision tree for tachycardia in the OR. The order of the questions really matters here. It's the same order you're going to use for boards. Okay, first, is the patient stable? Hypotension, ultramental status, ischemic chest discomfort, which you may not know about because they might be asleep. Acute heart failure means that they are unstable, and unstable means electricity. Unstable means electricity. Second, is the QRS narrow or wide? Narrow and regular is supraventricular, so vagal maneuvers, then adenosine. Yeah, vagal maneuvers can be tough. Maybe you can hold like a uh, max capacity breath or something of that nature. Let's see here. Um, Adenosine also has a diagnostic value in the scenario because transient AV blocks unmask flutter waves. Could be some flutter underneath there. Wide should be treated as VTAC unless you have solid evidence otherwise. And the single memorized exception is a pre-excited atrial fibrillation where the AV node blockers are contraindicated. Pre-excited atrial fib, WPW. Those are your clinical ones. Don't slow that down. What's your treatment? Procainamide. All right, we're going to pivot a little bit to um, normal EKG versus an ischemic EKG. Guidance explicitly says that no other aspect of electrocardiograph analysis is more important. When cardiac muscle is injured, it cannot maintain normal polarization, so it remains partially or totally depolarized all the time. Current, therefore, flows between the pathologically depolarized area and the normal polarized area, even between heartbeats of a current injury. Note the polarity carefully. The injured part is negative because the depolarized region emitting negative charges, while the remainder of the heart is neutral or positive. Three causes are given for mechanical trauma, infection, and most commonly ischemia from a local coronary occlusion. Something to know, ST elevation represents current injury and is the single most testable sentence in any of this section. ST elevation represents current injury. All right, this is, I think, a very important slide that you need to be aware of and know. Ischemia, injury, and infarction. These are not three separate diseases. They are 3 points in one timeline with three different EKG signatures. Reversible ischemia produces T wave inversion. Okay, T wave inversion is reversal and ST depression. Acute injury, still potentially salvageable, produces ST elevation. Necrosis produces a pathological Q wave, and the Q wave occurs after infarction and indicates a scar formation. So Q wave is like, hey, what happened to you? Let's look a little closer. They talk about biochemical reasons for this. Insufficient flow depresses metabolic metabolism in three ways: a lack of oxygen, excessive carbon dioxide, and a lack of nutrients. And without ATP, the membrane cannot repolarize. The ischemic cascade order matters enormously for us. Mechanical changes precede EKG changes, and symptoms come last or never. That is why an anesthetized patient can be well into ischemia before tracings move. All right, you're going to see this once or twice and probably a lot more. You got to know this. There is no ifs, ands, buts about it. You got to memorize this map cold because it converts into anatomical diseases and how you treat a patient. All right, 2-3 AVF are the inferior leads that correspond to the right coronary artery. V1 and V2 are septal. V3 and V4 are anterior, often called anterior septal leads. They both look at the LAD, or the left anterior descending artery. Leads 1, AVL, V5, V6 are lateral leads looking at the circumflex territory. We've hit this before, but notice a couple variations here. Inferior RCA infarctions, the RCA applies the SA and the AV node in 85 to 90% of the people. So expect the bradycardia, expect the AV block, get the epi drip, get the pads on the patient. And up to a third involve the right ventricle, which is completely preload dependent. And when you drop your preload because you're giving nitroglycerin, because you're having this, MONA, morphine, oxygen, nitrogen, aspirin, or excuse me, nitroglycerin and aspirin, you give that nitro, you're going to drop that preload, and RV infarct is treated with volume. And now this heart has no volume. Now your cardiac output goes down, and now you're in a really bad situation. So you've got to know what you're looking at and what type of leads. Infarct localization by vector analysis. Not going to spend a whole lot of time here. Universal rule: the positive end of the injury vector points towards normal muscle. The negative end points towards injured region. That one sentence localizes any infarct. All right, we talked about this a little bit before, but very high yield information here. Immediately after an acute heart attack, the injury potential is strong. They showed that after about 1 week, it's the opportunity for injury is diminished, and by 3 weeks is completely gone because new collateral flows have developed enough to reestablish most nutrition of the infarcted area. What does not go away is the Q wave because muscle has been lost, and a Q wave develops in lead 1 after an anterior infarct and in lead 3 after a posterior infarct, and it persists indefinitely as a marker of a scar. One clinical addendum worth knowing is that if ST elevation persists for weeks rather than resolving, think about a ventricular aneurysm, which could lead to, that whole side of the wall blowing out and instant death. So that's pretty important. Um, One thing I did want to bring up again, what we talked about before, is that Q wave needs to be greater than 25% of the height of the R wave. That's indicative of a true. All right, T waves reflect the sequence and the duration of repolarization. Slow conduction could be a bundle branch block, and the T is almost always opposite of the polarity of the QRS. Mild ischemia is the most common cause of shortness depolarization in that region. Increased potassium currents, inverting or like kind of a biphasic T wave. And digitalis toxicity, biphasic T, often earliest sign of toxicity. So super important. You don't see a lot of dig these days, but that's pretty important to know about. Moving on. Right, localizing ischemia and infarction, looking at a summary here. Use the territory to predict complications rather than merely naming a wall. Inferior RCA anticipate nodal ischemia producing bradycardial block and possible RV involvement, making the patient preload dependent. Anterior, left anterior descending artery, anticipate a large infarction territory, pump failure, and new conduction diseases possibly. A lateral or circumflex artery, often electrically quieter but still ischemic. You're going to have reciprocal changes, ST depression, opposite leads, 2, 3, and AVF, and increase your confidence that you're looking at true injury rather than a mimic. Okay, so look for those changes. All right, you're going to see this a lot during our lectures, and probably not going to apologize for that because it is so critical to you passing boards and understanding how to work your way through a question. Myocardial oxygen supply versus demand. You got to focus on the heart rate because the variable that appears on both sides of the balance. Increasing rate raises myocardial oxygen consumption directly and simultaneously shortens diastole. So Nagelhout talks about this that increased heart rate is the most important factor that negatively affects myocardial oxygen availability, and doubling the heart rate roughly doubles the demand. The second essential number is extraction. You know this. You're going to get pounded on this just repeatedly. You have to understand this. It's the extraction percentage is so high, 60 to 70%. So only flow can get you where you want to go. All right. Love that rhyme. You can take it to the bank. But you are so dependent on flow. Again, coronary perfusion pressure, aortic diastolic pressure minus left ventricular systolic pressure. Um, so, three words to think about: slower, smaller, better perfused. Slow the rate, lengthens diastole, lowers demand, shrink the ventricle, meaning reduce wall tension and preload, and perfuse it, getting that diastolic pressure up and making sure your oxygen content is enough to meet the standards. This is again something you're going to see a lot of, and you're going to have to know it. So the control of coronary blood flow, there's a vasodilatory theory, there's oxygen demand theory, myogenic theory, metabolic theory, long-term regulation. All of them work together to look at how that's being perfused. Local metabolism is probably the most important determinant of coronary vessel diameter and adenosine. The byproduct of ATP metabolism regarded as the primary substrate responsible for coronary vasodilation, and that's coupling the harder the myocardium works, the more ATP it breaks down, the more adenosine it releases, and the more flow it receives. Very interesting. Wonder how that occurred. The vasodilator theory and the oxygen demand theory are two major theories of local blood flow control. Myogenic theory adds the vessel intrinsic response to wall tension, and the metabolic theory explains the flow maintenance as pressure falls. Long-term regulation works by changing the degree of vascularity of the tissue and through angiogenesis um, from ischemic areas, and it's more effective than acute mechanisms. So again, it's long-term. Note that hypocarbia causes coronary vasoconstriction. And so that's different than cerebral flow, right? You overventilate somebody and make them hypocarbic to get more flow cerebrally. However, in a hypocarbic state, you're getting coronary vasoconstriction. Aggressive hyperventilation is not something you need to do with coronary artery disease. I'm going to cover a little bit of this. I know that I'm covering coronary steel in another lecture, but I'm going to cover this a little fast. So, law of Laplace, tension equals pressure times radius. So that's why a dilated ventricle is metabolically expensive, and why stress is a major determinant of myocardial oxygen demand. So you rearrange to pressure equals tension divided by radius. It gives the inverse relationship between the pressure and radius that appears in exam options alongside the direct relationship between pressure and tension. Coronary reserve is the gap between resting flow and maximal flow. Normal flow can rise 3 to 4 times. Distal to the significant stenosis, arterioles are maximally dilated, meaning that they have no reserve and entirely dependent on perfusion. That leads to coronary steel, where a potent vasodilator and the other healthy beds divert flow. The practical resolution, as long as adequate coronary perfusion is maintained, steel is largely avoidable. And we'll talk a little more about the concepts. There's two concepts of steel. We'll talk about that, I believe, in week 10. I think it's high yield, some of the stuff we've already covered, but important just to revisit. The pharmacology of myocardial ischemia. Match the drug to the specific physiological problem is really what you wanted to do here. Nitroglycerin acts predominantly on venous capacitance vessels. It reduces preload. Nitroprusside acts predominantly on arterial resistance vessels, so it reduces afterload, but there's some spillover into the venous side at high doses of nipride. That distinction is directly tested. Nitrates remain the first line therapy for acute angina attack because it redoses preload, lowers wall tension, therefore demand, and also dilates the epicardial coronary vessels, not the subendocardials, but the epicardials. Beta blockade improves the supply demand ratio both directions. Phenylephrine raises diastolic pressure and thus increases your cerebral or your coronary perfusion pressure, and with a helpful reflex bradycardia, which also lowers your demand. ACE inhibition is beneficial in ischemic heart disease, and calcium channel blockers are particularly useful in Prinzmetal angina or vasospastic angina. Remember, nitroglycerin in a right ventricular infarction can be catastrophic because it's preload dependent. So you need to stop that. You need to give volume in an inferior STEMI. Looking at monitoring ischemia in the heart room, lead selection is a deliberate clinical practice, not default. For a patient with a normal baseline EKG or none available, the preference order is V3, V4, V5, 3, and then AVF. For known coronary disease, a 5 cable system, monitor V3, AVF, uh, lateral lead 5, or lead 3. On a 3 cable system, AVF, V5, and lead 2 remains your rhythm lead. So you're often looking at lead 2 for rhythms and inferior changes, but really V5 and lead 2, that combination detects the large majority of intraoperative ischemic episodes. So you're looking at the LAD/circ in V5, maybe getting a little LAD view there, and looking at inferior rhythms as well. Adding V4 raises that, so you get a little more anterior view. All right, so what's important recognition preoperatively? Convert recognition into the first move because that's what board's questions ask, right? New ST depression usually demand ischemia. You need to deepen the anesthesia and analgesia, slow the rate, reduce the diastolic pressure, or excuse me, raise the diastolic pressure. Wow, that was a miss to me. Increase FiO2, get a 12 lead, right? New ST elevation, usually a transmural injury through the muscle. needing a STEMI response. New bundle branch block might be ischemic and hides further ischemia. Remember that left bundle branch block hides that J point. Wide complex tachycardia in an unstable patient is VTAC unless proven otherwise. You need to treat that with a little bit of electrical therapy. Pete T-wave progressing to widen QRS is hyperkalemia. Give him some calcium. Make sure you trust that IV, but give him some calcium. It's not going to hurt too bad. Low voltage with hypotension is tapenade unless echo says otherwise. Um, Note, I mean, it's just so important that you just don't look at a lead and do a lot of things off of that, right? You look at one lead, the same EKG leads, and the pressure is 120 over 70 or 70 over 40. Those are two different situations. You got a pressure of 70 over 40, and your end-tidal CO2 is dropped by 5. You're in a different scenario than you're looking at blood pressure 120 and your end-tidal CO2 is just fine, and your SpO2 is tracing right there regularly, but your EKG is just kind of like jacked up, and you're not sure what's going on. Don't treat in isolation. Take the whole picture and treat the patient accordingly. Boom, chicka, boom, boom. Concept map time. Here we go. Perioperative ischemia. On the left airways, supply fails. Low diastolic pressure reducing coronary perfusion pressure, tachycardia stealing diastolic filling, low arterial oxygen content, or a fixed and dynamic obstruction. On the right airways that demand rises, tachycardia again, increased wall tension from preload, increased afterload, or dilation through the law of Laplace, increased contractility, and hypertension. When supply falls below demand, the subendocardium fails first, and you might see some ST depression. If the process becomes transmural, you will see ST elevation. All right, pat yourselves on the back because we have made it to the last slide that I'm going to talk about tonight, or today, whenever you're listening. Um, every time you come to an EKG, you need a systematic approach. Time under pressure, structure beats intuition every time. You're never going to rise in the need of the moment. You're only going to sink to the level of your training. So work through it. Rate, rhythm, axis, intervals, morphology, ischemia, and take all that numbers and crunch them to a synthesis of what's going on. Okay, after that, go beyond the cardiologist and add the anesthesia layer. Okay, what is your ischemic risk on a supply demand type mindset? All right, how hemodynamically stable is this patient? If they're stable, optimize them. If they're unstable, light them up. Um, Safest anesthetic priority. What single move protects this heart right now? Boards are going to reward the safest physiologic priority, not the most aggressive intervention. When two options seem to work, what's the one that lowers demand and increases perfusion with less cost? When a patient's unstable, again, electrical therapy rather than a drug. Thank you for staying with me. Thank you for offering your time. I really appreciate that. There are some case studies that are coming up after this that we will go over in class when we kind of do a 30,000-foot view of a couple lectures at one time so that we can make a high yield on the time that we have together. If you do have questions, I'm happy to try to answer them. Again, a lot of the vector stuff is very challenging. Don't get overworked up about that. Know the access, know the ST changes, know the local regions that are being affected by coronary circulation, and I think you're going to be just fine, particularly when it comes to boards and what you need to know in this test for this lecture is pretty evident. So good luck and thank you again for your time. I hope you're doing great in anesthesia school, and it is a marathon. It's not a sprint. You can do this.